So we're going to start talking a little bit about legal and ethical issues involved in the care of patients with substance use disorders. So we can start with a case just to kind of set the stage in your mind. A 66-year-old female brought in by ambulance, coming in with abdominal pain and nausea. She appears very uncomfortable, anxious. She's writhing around in bed, looks miserable. Her vital signs, though, are fairly reassuring. Her heart rate's in the 80s, her blood pressure is 147/91, respirations are 14, and she's sitting while in room air. On your initial exam, she's got some generalized diffuse abdominal tenderness to palpation, but she's not peritonitic. But you note that she's screaming while the IV is being placed by the nurse, and it's an experienced nurse. And so you're trying to assess the picture. She looks incredibly uncomfortable. So you attend to her right away. The patient has a history of diabetes and hypertension, and from a social perspective, she has some limited English proficiency. She lives with several family members, including a son who's on the way. She denied any history of tobacco, injection drug use, or alcohol. And she mentions to you, and you note in her chart, that she had a similar presentation 2 weeks ago. There was a CT performed at the time that showed only possible delayed transit, and she was admitted under observation for pain control and PO intolerance and discharged the following day. She denies any other past surgical history or any prior episodes of the same pain in the past. So you're continuing to assess this patient, and she then makes an unusual request. She says, when my son arrives, you can tell him about my workup, the results, the plan of care, if I'm getting admitted to the hospital. But she then begs you not to disclose the names of any medications that she receives. This is kind of an unusual request. And so you reassure the patient that, you respect her privacy and that you're only going to disclose to any family members the things that she, gives you permission to do so. But you kind of file this away. It's kind of an unusual request. And the patient clarifies that, her family doesn't believe that she's in pain and they don't believe in pain medicine. So you kind of start to be concerned. Something's sort of not right about this situation. So let's take a step back and just talk about your assessment of pain in general, this patient and for any patient. When you're assessing a patient's pain and when you're doing right by our patients from an ethical perspective, it's helpful to take this biopsychosocial approach to consider not only the biology of what's going on with the patient. Is it a somatic type of pain? Is it a visceral pain? Do they have neuropathy type pain, cancer-related pain? But to talk a little bit with the patient about the psychology. What are their beliefs about the pain? What kind of control do they have? What life experiences and what else is going on in their perception of that painful experience? And then to consider those factors, the social factors, access to care, health literacy, life experience, and their living and work environment, and how the pain might be interplaying with those things. So when you go back to the patient, she is receiving 4 milligrams of morphine and 4 milligrams of ondansetron pretty quickly from her visit. The nurse has already come to find you to say that she's asking for something more. So, you're concerned, and instead of just offering an additional dose there, you actually return to reassess the patient. And she looks great. She's much more comfortable. Her repeat abdominal exam is now very reassuring. She's not tender, but she's continuing to say that she has a great deal of pain. And just around that time, the patient's son arrives and asks to speak with you. So he reports to you the patient's actually opioid dependent, and those are the words he uses. She's been out of her prescription medications, or she couldn't find them before calling the ambulance. And she receives hydrocodone, acetaminophen, and tramadol, and she frequently takes more than prescribed. Tonight, she accused her family of stealing her pills because she couldn't locate the bottles. She got really angry and called 911 because she said she was having uncontrolled abdominal pain. The son reports a similar situation when she came here 2 weeks ago, and he was with her on that visit as well, and then tells you that he found her unconscious last year, suspected overdose on these medications, but despite their concerns, she continues to be prescribed medication by the primary doctor. And then when she takes more than prescribed, she buys pills from a friend when she runs out. And so now this is painting a very different and kind of disparate picture of what might be going on with this patient. All right, so let's talk a little bit more about some ethical issues in general in pain management and kind of how this might help us approach a patient like this or this patient in particular. So when we think about the ethics of pain and our ethics as healthcare providers, we know that pain is a complex, multifactorial experience that's going to be modulated by several pathways, right? All along the fibers of those nerve fibers going up from your spinal cord into your brain, all of that is going to be a multifactorial experience. Patients with long-term opioid use may have some hyperalgesia due to the modulation and sensitization that happens along that pathway. And then we know that when patients are not receiving opioids when they're used to, they can have symptoms of withdrawal, and that can be painful. There can be body aches, there can be abdominal pain, there can be nausea. And so the withdrawal symptoms themselves can contribute to pain. We know that when we're treating patients with substance use disorder, and in particular with opioid use disorder, having adequate pain control, especially in the acute setting, is incredibly important to facilitate that workup and maintain a therapeutic alliance with a patient. It can be next to impossible to get a good exam on a patient who is in so much pain they can barely speak. And so making sure that we're addressing the individual and their pain control needs in that moment is incredibly important. We also know that patients with opioid use disorder in particular are undertreated for pain, and those patients risk leaving against medical advice, which has all kinds of downstream consequences for the patient. And there are some physicians and some providers who, question the ethics of treating patients with opioid use disorder with opioids. And I would say that yes, it's ethical to treat patients in pain with opioids, regardless of their history. If someone has a broken bone and they need pain control, it is our responsibility and our duty to our patients to alleviate that suffering. I would also add, though, that not all pain treatment needs to include opioids, although it may, and not all pain control needs to have a full opioid agonist. There are other pain options available. And multimodal pain therapy is going to be a really important part of our thought process around pain control. When you have a diagnosis related to chronic pain, the biopsychosocial lens that we talked about can be really helpful to illuminate some of those contributing factors, some of those social factors, some of those underlying mental health conditions, maybe some life stressors, maybe some other things going on that can potentially highlight some alternative solutions that can help the patient with their painful experience day to day. And then if a course of opioids ends up being appropriate for a patient, and it may and it will from time to time, what other steps should we be taking as clinicians to ensure the patient's safety and to protect ourselves as providers from liability? So when we think about the ethics of treating patients with pain, one of the things that I think we don't consider enough is that consideration of risk and benefit when we talk about opioids in particular. And that is tied very closely to the quantity and duration of the supply that we're giving patients. And so we know that the more pills that we prescribe for patients, the more likely it is that they're going to be used in a way that was different than prescribed, either by diversion or by use later or by use of a family member. We also should pay attention to, if we're treating a patient with chronic pain, a response that is escalating a dose without considering potentially the risk of that escalated dose or alternative complements to treat their pain, that multimodal pain therapy, referral to a pain specialist, considering adjuncts like NSAIDs or acetaminophen, making sure we're maximizing all of the types of tools that we have in our toolbox to treat pain. That's sort of our ethical responsibility before prescribing those opioids. It is on us to have adequate monitoring of abuse or co-prescription that puts patients at increased risk. In particular, things like co-prescribing of benzodiazepines and opioids put patients at higher risk of overdose. And so making sure we're doing our due diligence by our patients by monitoring those co-prescriptions or talking to them about the risks of polypharmacy especially. One thing that can be helpful is to consider a prescription of opioids or pain medication for a patient, almost like an informed consent, to have a conversation with the patient about the risks and the benefits, and that in your, opinion that this prescription is, going to help them more than the risks are, but there are risks and you should talk about them, and to come to some expectation around treatment and goals. And that might look like something like, I'm going to write you a 5-day supply of opioids, but I want you to take them only when your pain is beyond the level you can tolerate to get through your day-to-day activities. Every other day, I want you to be taking acetaminophen and ibuprofen 400 milligrams, alternating doses every 4 to 6 hours, so you have something else on board, and only take this medication when you're doing more activity than usual and your pain is intolerable, or describing those actual specific use, so that the patient has a good understanding of the expectations for treatment, how much those medications are going to reduce their pain, and that they're not out of line with what your expectations for the patient and their treatment are. So then we come to legal issues in pain management, and in particular for patients who are being prescribed opioids. So getting to some of the legal issues around prescribing controlled substances. So there are state-specific guidelines for reviewing patient records, and most states have these prescription drug monitoring programs where any filled prescription is going to be uploaded to a database that can be accessed by prescribers. Typically, they show Schedule 2 through 4 drugs. Some states go up to Schedule 5. And 48 states have a prescriber use mandate that requires you to check these records before prescribing an opioid. 43 states have just an enrollment mandate where any prescriber of controlled substances does need to be enrolled in the program. There are a number of exceptions, sometimes in acute care settings in particular, like an emergency department. Those prescribers are exempt, provided that they have a very specific type of care and treatment and a limited supply is being dispensed. And other states allow for a proxy. So something like a nurse practitioner or a PA in your practice may be the one who's authorized to do this on your behalf for your patients. You should document checking the prescription drug monitoring program when prescribing those controlled substances if that's required by your state. It is, tracked and recorded and certainly could be audited, but I think it provides that extra layer of, thoughtfulness in your charting that you're checking these programs as you're prescribing these medications. And then a note about confidentiality. So federal law around confidentiality of alcohol and drug abuse patient records is generally restricted to special kinds of treatment settings. So most primary and acute care settings don't fall under those rules for those special confidentiality provisions. And your charting, should accurately reflect your concerns and care. There's not a clear indication from the government as far as confidentiality that, you need to mark any charts that you discuss a concern about a patient's opioid use or prescription drug use as sensitive or handle those things in special ways, unless that's something that's unique to your practice. But just that, know that, when you are charting, you should just, document those things accordingly. There is no requirement in most places for consent for drug or alcohol testing that's, required in the course of your clinical care. But of course, you want to consider the value and limitations of that test. Many drugs stay in the system for quite a few days, that they may or may not reflect what's actually going on in front of you. There may be some impact to the patient on their possibilities for insurance and things downstream. And then certainly as more and more records have become patient-facing and open, if you don't discuss that testing with the patient, that may disrupt your patient-physician alliance. And so just consider those things when you're doing things like drug and alcohol testing. Additional prescribing regulations are also going to be state by state. And I wish there was a nice comprehensive way to sort of give some guidance on the day's supply of opioids that you can prescribe. But some states have very strict limits, up to 3 days for a first-time prescription, and others kind of go out to 7. Some states have no limit at all. Many states have longer prescriptions that are allowed if there's a documented rationale, a new malignancy is diagnosed, something like that, and that just needs to be reflected in your charting. There are some states, however, that do require offering naloxone, the reversal agent for overdose, for specific high-risk patients. And examples provided are things like patients who are receiving 90 morphine milliequivalents of medication per day, patients who are at high risk due to co-prescription, so thinking about that patient who has a benzodiazepine prescription and then has a new ankle fracture and is getting prescribed opioids, that might be a high-risk patient who should probably be offered naloxone, or any patient who's at increased risk of overdose. Not necessarily required to prescribe, but to offer in most places. So certainly check with your state medical board because all of these really state-specific guidelines are going to be, very local. Methadone is something that is still available to be prescribed for pain and in the hospital. However, still cannot be prescribed for the purposes of treating opioid use disorder outside of specialty clinics. So that still is something that's highly regulated in a different way as far as treating patients with opioid use disorder specifically. However, buprenorphine is no longer restricted in the way that it used to be. We used to need a special waiver to prescribe buprenorphine. That's no longer needed, or buprenorphine naloxone for the treatment of opioid use disorder. So now all prescribers with the DEA who are able to prescribe a Schedule III substance can prescribe buprenorphine for the purposes of treatment for opioid use disorder. It can also be used for treating pain in patients, especially patients with both opioid use disorder and a chronic pain condition. And there's no additional drug testing or anything required to prescribe. All right, so let's go back to our patient. We look back further into the patient's record, and we see, get some corroborating history from the story that the son's telling you, that maybe she had this overdose, and kind of dig a little bit further. And you do, in fact, see that about a year ago, she was seen in the emergency department for some respiratory distress, and there was a note by the ED physician that they suspected an overdose and used naloxone. And you dig a little further and you check the patient's records in the state prescription drug monitoring program. And again, you don't need the patient's permission to do this. This is actually part of your due diligence and your responsibility as a treating provider who may be considering treating this patient for pain. And you see that, yes, in fact, she has monthly prescriptions for tramadol, 50 milligrams every 8 hours, and hydrocodone acetaminophen, 10-325 every 6 hours, and a 30-day supply. And she's had that same prescription every 30 days for at least the past year, which is as far back as your records go in your state program. And the most recent fill of those pills was 7 days ago. Okay. So much of the history that the son's provided to you has now been corroborated by your medical records and then the state prescription drug monitoring program. And so, some further thoughts on your ethical and legal responsibility, as you consider when you see patients like this who maybe are very high risk for overdose, maybe are misusing the prescriptions that they're being provided, taking more than is prescribed and putting themselves at risk, potentially a patient who had an overdose a year prior. Is there something going on with that patient's primary care doctor? Are they acting inappropriately? That can be difficult to answer, in an acute visit, certainly. But you might want to consider, are you required to report this to the medical board or someone else? And in most states, there's just a recommendation that if you have a concern that a physician is acting inappropriately, that you report it to the board. So I think that's on you and your assessment of the situation and the patient to see if there's something that's very egregious or out of the realm of normal that might be, your responsibility to report. But there are sometimes tools within that prescription drug monitoring program where you can message the prescribers for that patient and let them know sometimes that there are several prescribers. They might not know about each other. Maybe there's been an interval for which they check the system every 6 months and they haven't noticed yet that the patient's getting prescriptions from several practitioners. And so some of the states do have tools where you're actually just allowed to communicate with those prescribers directly, and that could be an option in this case. But ultimately, your ethical responsibility, I think, is going to be with the patient and their family. And so, wrapping up this case, I think this conversation and the conversations that you have with the patient about these risks and benefits of opioids are going to be really important. So, as far as her acute presentation, she had a very comprehensive workup given her presentation at the door, and you reassure her that her results look wonderful. Everything's within normal limits. You've respected her wishes about her care, and she's already having a snack and PO trialing herself and seems to be, looking much more comfortable. And you mentioned that you suspect that potentially there was a component of opioid withdrawal that was relieved by your initial intervention. She came in looking miserable, having abdominal pain, having nausea, and, within seconds of getting a little bit of morphine after not being able to find her medication, she was relieved of those symptoms. And that, in addition to your workup, maybe pointed you in this direction. Patient then asked you for something for the pain for home. And this is a time where having that drug monitoring report could be really helpful. So showing her, here's a report of all the things I see you've been prescribed, and you actually got 30 days worth of medication just last week. And I'm actually concerned, if you've gone through this quickly, this might be a sign that this medication isn't serving you well and interfering with your life, and that we're not doing a good job of controlling your pain day to day or whatever else is going on that's requiring you to take these medications. She still doesn't really have a clear diagnosis of why she's on them in the first place. You discuss further with the patient and her son some other options for treatment, some multimodal pain therapy, some GI preparations that could be helpful for this, diffuse epigastric pain that she sometimes gets from time to time that may or may not be related. And you talk to her a little bit about options for cessation or cutting back on these opioids, including things like buprenorphine, which can be used for both pain and opioid use disorder. And the patient considers it and declines, but she says she'll think about it. And I think, being willing to have these conversations and plant the seed with the patient and the family to know that there are other options, especially as some of the regulations around buprenorphine have diminished, may be really helpful for patients to have at least the knowledge and the tools to explore those options with their primary care doctor. You discuss the risks of polypharmacy and, her patterns of taking more than prescribed as you've sort of identified this in the course of her visit, and then offer the son some naloxone for home and the patient some naloxone for home, which can be thought of as, something that you put in the medicine cabinet, like an EpiPen for someone with anaphylaxis, and is sort of on us as, ethical prescribers to consider, I've identified someone who may be at high risk for overdose, who's potentially had an overdose in the past. This is a patient who would maybe benefit from having this at hand. All right. So in conclusion, our legal regulations around treating patients with substance use disorder and opioid use disorder mainly surround these state-specific policies on prescription drug monitoring programs and the amount and number of days of supply that you can dispense to a patient. They're all going to be something that would be worth checking with your state medical board because they are state-specific. The ethical issues, however, are numerous, right? We must first do no harm and alleviate our patients' suffering. But when we consider patients, especially those with chronic pain or with opioid use disorder, having that toolkit of that biopsychosocial model and considering sort of the entire pain experience can be really helpful to us and the patient. And in doing so, you might identify some non-pharmacologic contributors to the pain and to the pain relief while strengthening that therapeutic alliance and, keeping yourself, true to your own ethical prescribing practices. And there's some references. Thank you.